Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 185 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, which of the therapeutic options listed below would be the best treatment option for a patient with vancomycin-resistant native valve endocarditis caused by Enterococcus faecium with a daptomycin MIC of 3 micrograms per milliliter? Would it be A. Daptomycin 10 mg per kilogram IV once daily plus tobramycin 1 mg per kilogram IV thrice daily, or B. Daptomycin 10 mg per kilogram IV once daily plus ceftaroline 600 mg IV thrice daily, or C. Daptomycin 8 mg per kilogram IV once daily plus linezolid 600 mg IV twice daily, or would it be D. Daptomycin 8 mg per kilogram IV once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Daptomycin 10 mg per kilogram IV once daily plus ceftaroline 600 mg IV thrice daily. Daptomycin should be administered using a high dose, that is, 10 to 12 mg per kilogram daily, for the treatment of VRE native valve endocarditis caused by vancomycin-resistant Enterococcus. Combination therapy is preferred over monotherapy, although this preference is based only on expert opinion. In vitro synergy has not been observed from use of the combination of daptomycin and linezolid for the treatment of native valve endocarditis caused by vancomycin-resistant Enterococcus. Daptomycin combined with ceftaroline provides in vitro synergy and is the recommended combination therapy for native valve endocarditis caused by vancomycin-resistant Enterococcus. Tobramycin does not demonstrate synergy with daptomycin in the treatment of enterococcal endocarditis. Gentamicin demonstrates in vitro synergy. Therefore, this combination is not an appropriate option. Please advance to the next question. And the next question reads, your cardiologist admits BLB, a 48-year-old male patient with a 24-hour history of fever and chills and new-onset fatigue. His blood cultures are negative on admission. However, a transesophageal echocardiogram that was performed to assess left ventricular function shows a small mobile echo density on his aortic valve, raising suspicion about the possibility of endocarditis. So my question to you is, which of the following microorganisms should the empiric antibiotic treatment used target during the management of BLB's suspected native valve endocarditis? Should it target A. Candida species, HACEK organisms, that is, Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella, and aerobic gram-negative bacilli, or B. Bartonella species, Coxiella burnetii, and HACEK organisms, that is, Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella, or C. Staphylococcus aureus, Streptococcus species, and aerobic gram-negative bacilli, or should it cover D. Streptococcus species and Enterococcus species? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Staphylococcus aureus, Streptococcus species, and aerobic gram-negative bacilli. Enterococcus species are not typically implicated in acute-onset native valve culture negative endocarditis. Acute-onset native valve culture negative endocarditis is commonly caused by Staphylococcus aureus, Streptococcus species, and aerobic gram-negative bacilli. These pathogens should be targeted by empiric antibiotic therapy in this patient. Although while Bartonella spp, Coxiella burnetii, and HACEK organisms can cause culture-negative endocarditis, they are less common and typically associated with risk factors. Candida species are not typically implicated in acute-onset native valve culture-negative endocarditis. Other organisms are more common and should be targeted with empiric antibiotic therapy. Please advance to the next question. And the next question reads, which of the statements listed below is correct regarding the 2013 observational study comparing the effectiveness of ampicillin plus gentamicin, abbreviated as AG, with ampicillin plus ceftriaxone, abbreviated as AC, for the treatment of infective endocarditis caused by Enterococcus faecalis? Is it A. The study results can be applied to patients with infective endocarditis caused by Enterococcus faecium, or B. The risk of treatment relapse was significantly higher in patients who received AC than patients who received AG, or C. The study results are relevant only for patients with Enterococcus faecalis and high-level aminoglycoside resistance, abbreviated as HLAR, or is it D. Significantly more patients in the AC group than patients in the AG group had prior chronic renal failure at baseline, but AC was associated with less acute renal failure? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Significantly more patients in the AC group than patients in the AG group had prior chronic renal failure at baseline, but AC was associated with less acute renal failure. Significantly more patients in the AC group than the AG group had prior chronic renal failure at baseline, probably because the choice of treatment was left to the provider's discretion at several of the participating hospitals. The AC regimen was associated with less acute renal failure than AG despite this discrepancy in prior chronic renal failure at baseline. The study was conducted in patients with both HLAR and non-HLAR strains of Enterococcus faecalis, so the results are relevant for both HLAR and non-HLAR E. faecalis. There was no significant difference between the two treatment groups in the incidence of treatment relapse. Patients with infective endocarditis caused only by Enterococcus faecalis were included in this study. Whether similar synergy would be observed from the use of AG or AC in patients with infective endocarditis caused by Enterococcus faecium is not known. The study results should not be extrapolated to these patients. Please proceed to the next question. And the next question reads, in which of the situations listed below would it be appropriate to treat with gentamicin 3 mg per kilogram IV every 24 hours as part of combination therapy for infective endocarditis? Is it in A. Vancomycin plus gentamicin for the treatment of native valve Enterococcus fischum endocarditis with a penicillin allergy, or B. Vancomycin plus gentamicin plus rifampin for treatment of prosthetic valve methicillin-resistant Staphylococcus aureus, MRSA endocarditis, or C. Penicillin plus gentamicin for the treatment of native valve highly penicillin-susceptible viridans group Streptococcus endocarditis, or is it D. Nafcillin plus gentamicin for the treatment of native valve methicillin-susceptible Staphylococcus aureus, MSSA endocarditis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Penicillin plus gentamicin for the treatment of native valve highly penicillin-susceptible viridans group Streptococcus endocarditis. Gentamicin should not be used for the treatment of native valve MSSA endocarditis because improved outcomes have not been demonstrated, compared to anti-staphylococcal beta-lactam therapy alone, and gentamicin causes unnecessary toxicity, specifically renal toxicity. Studies have demonstrated that treatment with a beta-lactam antibiotic and once-daily gentamicin is sufficient for the treatment of streptococcal endocarditis. Once-daily gentamicin has not been studied in patients with prosthetic valve MRSA endocarditis, so traditional dosing with the daily dose given as divided doses should be used. The results of experimental animal and human studies using once-daily gentamicin for the treatment of Enterococcus endocarditis are conflicting. Therefore, traditional dosing with the daily dose given as divided doses should be used. Please proceed to the next question. And the next question reads, GMB, a 37-year-old female patient presents to your accident and emergency department and is admitted shortly afterwards. Her chief complaint is fever, leukocytosis, and erythema surrounding her pacemaker site. She has a past medical history significant for a permanent pacemaker for atrioventricular block. A TEE is done and it shows no vegetations on the leads or heart valves, indicating isolated pacemaker pocket infection. Her blood cultures have been reported on 2 occasions as negative to date. So my question to you is, which of the following would be the most appropriate antibiotic and duration of treatment for GMB's infection? Would it be A. Cefepime plus vancomycin for 14 days, or B. Linezolid for 10 days, or C. Ciprofloxacin for 10 days, or would it be D. Co-amoxiclav for 28 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Linezolid for 10 days. Cardiovascular implantable electronic device infections are commonly caused by Staphylococcus species, so treatment with linezolid for 10 days is appropriate. Amoxicillin, clavulanate does not provide adequate coverage for methicillin-resistant Staphylococcus aureus, and it provides additional gram-negative and anaerobic coverage that are not needed. A 4-week duration of therapy is too long for this patient who has negative blood cultures and an isolated pacemaker pocket infection. Ciprofloxacin does not provide adequate coverage for Staphylococcus species, the most common cause of cardiovascular implantable electronic device infections. Treatment with linezolid for 10 days is appropriate for this patient who has negative blood cultures and an isolated pacemaker pocket infection. An isolated pocket infection in a patient like GMB with negative blood cultures can be treated for 10 to 14 days. The use of vancomycin plus cefepime provides antimicrobial coverage that is too broad. Pseudomonal coverage is not needed for this patient who has negative blood cultures and an isolated pacemaker pocket infection. Please progress to the next question. And the next question reads, PTB, a 42-year-old male patient was admitted at your hospital for sepsis and started on vancomycin and cefepime 4 days ago. He has a past medical history significant for IV drug abuse. PTB was found to have native tricuspid valve methicillin susceptible Staphylococcus aureus, MSSA endocarditis complicated by a brain abscess. He has no known drug or food allergy. So my question to you is, which of the following would be the most appropriate next steps to manage PTB's infection? Would it be A. Stop vancomycin and cefepime and start cefazolin, or B. Stop vancomycin and cefepime and start ciprofloxacin and rifampin, or C. Stop vancomycin and cefepime and start nafcillin, or would it be D. Stop cefepime, continue vancomycin, and start rifampin? I will give you 10 seconds to choose the correct answer to this question from the listed options. Would it be A. Stop vancomycin and cefepime and start cefazolin, or B. Stop vancomycin and cefepime and start ciprofloxacin and rifampin, or C. Stop vancomycin and cefepime and start nafcillin, or would it be D. Stop cefepime, continue vancomycin, and start rifampin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the next question reads, in which of the patients in the clinical scenarios described below would it be reasonable to administer antimicrobial drug therapy for the prevention of infective endocarditis? Would it be A. A patient with a history of endocarditis caused by methicillin-resistant Staphylococcus aureus, MRSA, who is scheduled for a tonsillectomy, or B. A patient with a history of congenital heart disease status post-prosthetic patch who is undergoing routine dental cleaning, or C. A patient with a bioprosthetic mitral valve who is receiving dental X-rays, or would it be D. A patient with history of aortic stenosis who is scheduled for a root canal? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. A patient with a history of endocarditis caused by methicillin-resistant Staphylococcus aureus, MRSA, who is scheduled for a tonsillectomy. I will begin by commenting that aortic stenosis is not considered a cardiac condition with a particularly high risk of adverse outcome from infective endocarditis, so antimicrobial prophylaxis is not recommended. Although this patient is at high risk for infective endocarditis because of a bioprosthetic mitral valve, antimicrobial prophylaxis is not recommended for dental X-rays. Although this patient is at high risk for infective endocarditis because of a history of prosthetic patch for congenital heart disease, antimicrobial prophylaxis is not recommended for routine dental cleaning. Antimicrobial prophylaxis is appropriate for a patient with a history of infective endocarditis who is undergoing an invasive procedure, such as tonsillectomy. Please advance to the next question. And the next question reads, JMW, a middle-aged patient with confirmed methicillin-resistant Staphylococcus aureus, MRSA, native valve endocarditis undergoes tricuspid valve, TV, replacement 10 days after starting appropriate antimicrobial therapy and 7 days after negative blood cultures are documented. Cultures of his TV are positive for MRSA with the following timeline. On February 2, blood cultures 2 of 2, MRSA. On February 3, blood cultures 2 of 2, MRSA, and appropriate antimicrobial therapy started. February 4, blood cultures 1 of 2, MRSA. On February 6, blood cultures 2 of 2, negative. On February 7, blood cultures 2 of 2, negative. On February 13, TV surgery, TV valve cultures with MRSA. So my question to you is, which of the days listed below would be considered day 1 of therapy? Would it be A. February 13, or B. February 6, or C. February 3, or would it be D. February 2? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. February 13. Because valve cultures are positive, the day of valve surgery should be considered day 1 of therapy, that is February 13 is the correct day, not the day of first negative blood cultures. It should be considered day 1 of therapy. The day appropriate antimicrobial agents were initiated is not the first day of therapy. The first day of positive blood cultures should not be considered day 1 of therapy either. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 186.